Welcome to PNB Wellness Academy. Today, we're reviewing neurotransmitters made simple, specifically the information you need to recognize for PMHNP board preparation and clinical psychopharmacology. Instead of memorizing random lists, I want you to think about three things. Where is the neurotransmitter coming from? What does it normally do? And what happens when the system is increased, decreased, or blocked? The major neurotransmitters we're going to focus on are acetylcholine, dopamine, serotonin, GABA, glutamate, norepinephrine, and histamine. And then we'll briefly cover neuropeptides. So let's start with acetylcholine. Acetylcholine is important for learning, memory, attention, arousal, muscle contraction, autonomic function, and REM sleep. In the brain, an important cholinergic region is the basal forebrain, including the nucleus basalis of Menert. One of the most important associations is Alzheimer's disease, which equals decreased acetylcholine activity. Loss of cholinergic neurons contributes to impaired memory and cognition. That explains why medications such as donepezil, rivastigmine, and galantamine inhibit acetylcholinesterase, which increases the availability of acetylcholine. There are two major acetylcholine receptor families. The nicotinic receptors are ligand-gated ion channels, and the muscarinic receptors are G-protein coupled receptors. For psychiatric medication management, remember the effects of the anticholinergic activity: dry mouth, constipation, urinary retention, blurred vision, and cognitive impairment or confusion. A useful mnemonic is can't see, can't pee, can't spit, and can't poop. Older adults are particularly vulnerable to cognitive effects of medications with a high anticholinergic burden. Parkinson's disease involves decreased dopamine in the nigrostriatal pathway, creating a relatively imbalance between dopamine and acetylcholine. So we want to remember Alzheimer's has decreased acetylcholine and Parkinson's has increased acetylcholine. Next neurotransmitter is dopamine. Dopamine is one of the highest yield neurotransmitters for PMHNP boards. I want you to think reward, motivation, movement, attention, and prolactin. But knowing dopamine alone isn't enough. You need to know the four dopamine pathways. So let's start with the mesolimbic pathway. When you see mesolimbic, I want you to think positive symptoms and reward. It originates primarily in the ventral tegmental area, or VTA, and projects to the limbic structures, including the nucleus accumbens. It is involved in reward, pleasure, motivation, reinforcement, and addiction. In schizophrenia, the mesolimbic dopamine is increased, which equals positive symptoms. And that includes hallucinations and delusions. Antipsychotic D2 blockade in this pathway helps to decrease the positive symptoms. The next pathway is mesocortical. This pathway is related to cognition, and it originates in the VTA and projects to the prefrontal cortex. It contributes to executive functioning, attention, motivation, affect, and cognition. In schizophrenia, the mesocortical dopamine is decreased, and you want to think of the negative and cognitive symptoms. And that's avolition, anhedonia, flat affect, impaired attention, and cognitive difficulties. This is high yield, so you want to remember mesolimbic equals too much dopamine, which results in positive symptoms in their pathway. Mesocortical equals too little dopamine, and that results in negative cognitive symptoms when there's too little dopamine in that pathway. The next pathway is the nigrostriatal pathway. It runs from the substantia nigra to the striatum and controls movement. So when you see nigrostriatal, you want to think movement. When dopamine is deficient, Parkinsonism can occur. When the D2 receptors are blocked by antipsychotics, extrapyramidal symptoms, or EPS, can occur. This includes acute dystonia, akathisia, Parkinsonism, and tardive dyskinesia. That is extremely important for your PMHNP medication management. And the last pathway is the tuberoinfundibular pathway. It runs from the hypothalamus toward the pituitary. Dopamine normally inhibits prolactin release. So remember, dopamine blocks prolactin. If an antipsychotic blocks dopamine in this pathway, prolactin can increase. And hyperprolactinemia can contribute to galactorrhea, amenorrhea, sexual dysfunction, and reproductive endocrine effects. So you want to remember, increased dopamine in the mesolimbic pathway equals positive symptoms. In the mesocortical pathway, if you have decreased dopamine, you have negative cognitive symptoms. In the nigrostriatal pathway, you want to remember that is correlated to movement. When you have decreased dopamine in this area, it may result in Parkinsonism and EPS symptoms. And then with the tubular infundibular pathway, decreased dopamine can increase prolactin. Our next neurotransmitter is serotonin. Serotonin is also called 5-HT. Its major CNS cell bodies are located in the raphe nuclei of the brainstem. So when you see serotonin, you want to think mood, anxiety, sleep, appetite, impulsivity, sexual function, and pain modulation. Serotonergic medications are central to the treatment of depression, anxiety disorder, PTSD, and OCD. If a board question asks you to connect OCD with a classic neurotransmitter system, you would think serotonin. SSRIs are first-line pharmacologic treatments for OCD. A large proportion of the body's serotonin is located in the gastrointestinal tract. Although peripheral serotonin and CNS serotonin serve different functions, this helps explain why serotonergic medications commonly produce GI adverse effects such as nausea and diarrhea. Platelets obtain serotonin through uptake rather than synthesizing it themselves. SSRIs can interfere with platelet serotonin uptake, which can contribute to an increased bleeding tendency, particularly when combined with NSAIDs, anticoagulants, or other medications affecting hemostasis. This is extremely high yield. We want to discuss serotonin syndrome. Serotonin syndrome results from excess serotonergic activity, often after combining serotonergic medication, increasing doses, overdose, or interacting drugs. Think of the three major categories: mental status changes, agitation and confusion, autonomic hyperactivity, diaphoresis, tachycardia, hypertension, hyperthermia, and neuromuscular abnormalities, tremor, hyperreflexia, and clonus. For boards, clonus and hyperreflexia are particularly important clues. Don't confuse serotonin syndrome with neuroleptic malignant syndrome. Serotonin syndrome tends to have hyperreflexia and clonus. NMS classically has severe lead pipe rigidity and elevated CK in the setting of dopamine blockade. Let's discuss GABA. GABA stands for gamma aminobutyric acid. It is a major inhibitory neurotransmitter in the CNS. So when you see GABA, you want to think brakes. GABA decreases neuronal excitability. Clinically, GABA is associated with calming, decreased anxiety, sedation, muscle relaxation, and seizure suppression. Reduced inhibitory GABA activity has been implicated in anxiety and seizure susceptibility. Benzodiazepines enhance the effect of GABA at GABA-A receptors. The board-level mechanism is benzodiazepines increase the frequency of chloride channel opening. Barbiturates increase the duration of chloride channel opening. That distinction is worth remembering because GABA-enhancing drugs depress CNS activity. Combinations with other CNS depressants can significantly increase sedation and respiratory depression risk. Now let's talk about glutamate. When you see glutamate, you want to think gas. Glutamate is the major excitatory neurotransmitter in the CNS. It plays important roles in learning, memory, synaptic plasticity, and neuronal activation. One of its major receptors is the NMDA receptor. Excessive glutamatergic activity can contribute to excitotoxicity and seizure activity. Glutamatergic NMDA dysfunction has also been implicated in schizophrenia. Decreased glutamatergic activity in schizophrenia can result in negative symptoms and cognitive deficits. Now let's move on to norepinephrine. Norepinephrine helps you stay awake, alert, attentive, and ready to respond. An important CNS source is the locus coeruleus in the pons and brainstem. Norepinephrine contributes to attention, concentration, vigilance, arousal, energy, and the stress response. Increased noradrenergic activity can contribute to hyperarousal, tachycardia, increased blood pressure, tremulousness, and anxiety symptoms. Reduced noradrenergic signaling is associated with symptoms such as low energy and impaired concentration. SNRIs increase serotonin and norepinephrine signaling. Atomoxetine selectively inhibits norepinephrine reuptake and is used for ADHD. Norepinephrine is therefore particularly important when thinking about depression, anxiety, hyperarousal, and ADHD. For PMHNP boards, the major neurotransmitter systems associated with ADHD are dopamine and norepinephrine. Both are important in prefrontal cortical circuits involved in attention, executive function, impulse control, and working memory. So now we'll discuss histamine. Histamine contributes to wakefulness, arousal, appetite, and alertness. For PMHNPs, the most important connection is usually the H1 blockade. Blocking central H1 receptors can cause sedation, weight gain, and increased appetite. This is clinically relevant when several psychotropic medications. So when you see significant H1 antagonism, think sleepy and hungry. Now we're going to move on to neuropeptides. Neuropeptides act as signaling molecules and neuromodulators. Endorphins and other endogenous opioid peptides and substance P. Endogenous opioid peptides participate in pain modulation, reward, stress responses, and reinforcement. Substance P is involved in pain transmission and stress-related signaling. Now we're going to connect everything together. These items you really want to know and put into memory. We'll start with Alzheimer's disease or impaired memory. You want to remember that there is decrease in acetylcholine, decreased glutamate, and increased dopamine. And on the opposite, we have Parkinson's. It has increased acetylcholine and decreased dopamine. So be sure to remember those. Next, we'll discuss schizophrenia. And we need to know where dopamine is increased and decreased in the pathways. So increased dopamine is in the mesolimbic pathway, decreased dopamine is in the mesocortical pathway, and these are very important to remember. There's also decreased serotonin activity and GABA activity and decreased glutamate with schizophrenia. And with the decreased glutamate, you want to remember there's negative symptoms of schizophrenia. In autism, you'll see impairment in the glutamate, serotonin, and GABA areas. ADHD, you'll see impairment in dopamine, serotonin, and norepinephrine. Antisocial disorder, you'll see decreased dopamine. In psychosis, you'll see increased glutamate and increased dopamine. Addiction, there's an impairment in the GABA and dopamine areas. Bipolar disorder, you'll see increased glutamate. OCD, you'll see decreased serotonin and norepinephrine. Tourette's, you'll see an impairment in dopamine, serotonin, GABA, glutamate, and norepinephrine. In substance abuse disorders, you'll see decreased opioid neuropeptides and decreased dopamine. And then in mood, you'll see an impairment in serotonin and norepinephrine. I hope this was helpful. Come back to PNB Wellness Academy for more PMHNP board review made simple.